I would like to give you a short view on the myocardial function imaging in congenital heart disease, namely hypoplastic left heart, and some issues on cardiac interventions. As you all know, the hypoplastic left heart is one of the most severe forms of congenital heart disease, and there are different forms of hypoplastic left heart, and with the very advanced machines from Toshiba, we have the possibility to depict very small structures in the heart, and we can then evaluate whether it's a mitral atresia, aortic atresia, or mitral stenosis, aortic atresia with endocardial fibrillar elastosis, which you see here on the septal side and on the free wall. But why is it important perhaps to know about the myocardial function during gestation? It's because the neonate completely and the child completely relies on the right ventricle in a long-term view. And as you know, it depends on the healthcare systems how many congenital heart diseases will be detected prenatally. But if not, the hypoplastic left heart after birth, the neonate will probably die because of the closure of the arterial duct and the reliance of the systemic blood supply on the opening of the shunts. And if not, or in other terms, the detection of congenital heart disease and the detection of hypoplastic left heart is very, very important before birth. And you might know that there are different kinds of approach of palliation after birth for congenital heart disease or for hypoplastic left heart. There's the classical form of Norwood, and there's the hybrid approach, which has been elaborated in Giessen, in the Pediatric Heart Center. And the hybrid approach is basically the perpetuation of the fetal circulation. You perform an arterial bending of the pulmonary arteries and a ductal stenting, and by this, the fetal circulation is perpetuated into the neonatal period. And this might open windows for new kind of approach, because some neonates with hypoplastic left heart complexes might become biventricular after some month, and if you perform a Norwood procedure in the early neonatal period, you have a univentricular situation immediately. And if you rely on hybrid approach, in those cases you might achieve a biventricular circulation in some patients. But we try to elaborate prenatally whether there would be some differences among different forms of hypoplastic left heart. And in the long term, the outcome of hypoplastic left heart is depends on the kind of hypoplastic left heart, as I said, mitral atresia, aortic atresia, or other forms. And you see here that the form with mitral stenosis and aortic atresia, which normally is associated with endocardial fibrillar elastosis, might have the worst outcome after 10 years. So we try to elaborate by the advanced techniques of myocardial imaging with the Toshiba machines, how we could depict differences among different forms of hypoplastic left hearts. And this was the first aim in or the second aim. The first aim was to study the feasibility of the different ultrasound techniques. As you know, we have the M mode, we have the PV Doppler and a PV TDI and a color TDI. And we applied all of them to the hypoplastic left heart fetus. And you know that in tissue Doppler, the blood flow Doppler signal is of low intensity and of high velocity. And in the tissue Doppler, we have a high intensity and low velocity signal. You need a special setup, and you might evaluate your fetus by pulsed wave tissue Doppler or by color-coded tissue Doppler. You know that the advances of pulsed wave tissue Doppler are high temporal resolution, but a disadvantage is that there might be no there's no evaluation of deformation parameters. So you probably all know those curves, and just to remind you that the S prime velocity is a velocity of the systolic downward motion of the annulus towards the apex, and the E prime velocity is a velocity of the early diastolic movement away from the apex, and the A prime velocity is a velocity of the movement of the annulus associated with atrial contraction. So you get multiple informations on the cardiac cycle, evaluating the different velocities and time intervals. And you know that the MPI has been elaborated extensively in other forms of fetal abnormal conditions like TTTS or diabetes of the mother. In color TDI, we have the opportunity of the evaluation of global and regional myocardial segments with a Cine loop, and this opens other new information, probably in the evaluation of fetuses with congenital heart disease. This is how it looks like in the evaluation of color tissue Doppler. And in a first study, we had a multi-center study in Germany to evaluate whether different sizes of region of interest would be of importance in the evaluation of the time intervals and of the velocities, and this was not the case. So what are now the velocities telling us? The S prime, and this comes from the adult echo information, the S prime corresponds to the left ventricular systolic function. And the E prime corresponds to diastolic function, as does the ratio of E to E prime. And this is a very sensitive marker of diastolic dysfunction. The higher this ratio is, the worse is the diastolic function. And A prime is an information on the AV valve inflow profile and on the diastolic function of the right ventricle. So these were the two papers which came out by our group on this topics. And we had there 20 fetuses with hypoplastic left heart included. You see the inclusion criteria, and 20 controls, and these were matched pairs. And this was done by Toshiba machines. And you see here the basic information of the PV-TDI, which was also seen in the color-coded tissue Doppler. We had a difference in the tricuspid valve PV Doppler flow of the E wave, and we had an A prime difference. You see here that the E to E prime ratio was higher in the hypoplastic left heart fetuses. This was overall the cohort, and we saw that, or we concluded that there would be a diastolic, an alteration of diastolic function of the right ventricle in hypoplastic left heart cases. And then we saw, and this is again, this is the timing and the velocities in color-coded tissue Doppler, and you see here that the A wave in hypoplastic left heart was increased, and this means that the right ventricular filling relies more on the atrial contraction in those cases of hypoplastic left heart. We then also, and this is also very important, to always look at the inter- and intra-observer variability, and we saw that this is a reasonable result for this very advanced technique, which is really, one has to say, operator dependent, and you have to get involved in the techniques very deeply. Then we went a step further, and we wanted to have information on different types of hypoplastic left heart, and we then looked at the group of mitral stenosis and aortic atresia, which I showed you would be expected to have the worst outcome in the long term. And then at first look we saw that the right ventricle shows an increased sphericity, which means that the diameter, the short axis diameter becomes greater and the long axis diameter is shortened compared to hypoplastic left heart forms without endocardial fibroelastosis, which might lead to the notice that the function of the right ventricle in endocardial fibroelastosis is influenced by endocardial fibroelastosis. And also we saw that which was not the case in the hypoplastic left heart cases without endocardial fibroelastosis, that the long axis function was also altered in those cases. We saw, for example, TAPSI were significantly lower in those cases over gestational age, and the systolic, the S prime velocities were lower. So there was quite a even more altered right ventricular function in those cases. And we try to link this information now to our pediatric cardiologists, colleagues, and pediatric cardiac surgeons to share this information for their decision making, perhaps, of to see whether this is an important information for them to choose either a palliation, Norwood, or hybrid, and we will evaluate this in the long term. But this is interesting and new information that myocardial function of the right ventricle is altered in different forms of hypoplastic left heart. Then we can move to another topic which is discussed now in the scientific community, and this is about the brain and the congenital heart disease. And we see here that we analyzed 75 fetuses with left heart defects, and we divided them into antegrade flow in the aortic arch and reverse flow in the aortic arch, and we looked at the pulse wave tissue Doppler analysis and M-mode analysis of those cases, and we didn't see any significant alteration during gestation, but we saw, and this is what is discussed very heavily in the community, that the head circumferences of those fetuses comes down from the first time point of evaluation at 20 weeks over gestational age, and just this is the time point before birth, and you see that there's a significant decrease, however, within the reference ranges of head circumference, but those cases with retrograde flow in the aortic arch show very decreased, or show decrease in head circumference over gestational age. So for myocardial function, pulse wave and color-coded myocardial function, one can say that enhanced right ventricular non-compliance reflected by altered tricuspid valve pulse wave Doppler velocities were found, and also different tissue Doppler and color Doppler, tissue Doppler informations. And for the cases with endocardial fibroelastosis, we saw an architectural adaptation with increased sphericity of the right ventricle and an altered long axis function which was not shown in other forms of hypoplastic left heart. Then our group, and namely Christian, elaborated the topic of speckle tracking with the Toshiba technique, and we showed that the assessment of myocardial deformation parameters by 2D wall motion tracking is feasible, technically feasible, and this is also a tool which might promise reliable analysis of myocardial function in the future. And Christian showed that, this is discussed also in the community, whether this relies on high frame rate acquisition, and he did an analysis of the frame rates by DICOM of 30 and 60, and there were no major significant differences using 30 or 60 frame rates by DICOM. And there's another study going on by using acoustic frame rates, and we will have these information in due time. Now to the cardiac intervention topic. In Gießen we have a intervention program, but we have few cases, and we try to use another access to the fetal heart, because we think that it might not be reasonable to stick a needle into the thorax of the fetus, and we try to elaborate this access in a sheep model, which I will show you now. This is a transhepatic access of the hepatic vein, and this was a joint work with Melbourne Monash University, and we did the access study. We tried to look whether we could access the fetal heart by by the puncture of the hepatic system of the fetal sheep. And we did this by a percutaneous puncture into the fetal right hepatic vein, but this is also possible in the left hepatic vein, depending on the lie of the fetus or of the fetal sheep. And then we inserted the needle, and I will show you how this is performed. You see here the needle going into the right hepatic vein, and then it's getting access to the vena cava, lower vena cava, and then the wire is pushed towards the right atrium, and here you see that the right atrium is accessed. And in a first study we did 9 sheep, and we saw that we could get access to the right heart in 8 sheep, and in 1 sheep it was not possible because of the position of the fetal sheep. Then we had another study where we looked at whether we could pass the tricuspid valve and we could pass the pulmonary valve, and this was possible in those 8 sheep. And the third study which we performed there is that we tried to open or put a stent into the foramen ovale, because you know that there might be some congenital heart disease where the foramen ovale is sealed. You know this as a restrictive foramen ovale or foramen ovale closure, which occurs in about 8% of hypoplastic left heart or other left heart obstructions. And there we put a stent into the foramen ovale, and I'll show you again the movie. And here you see the stent accessed into the foramen ovale, and here is the opening of the stent. Okay, and then in the next step, this is the pathological specimen after the sacrifice of the fetal sheep. And after after that, we and this is done in a joint procedure by a pediatric cardiologist, by Professor Schranz, who is a great interventionalist. And then we tried to occlude the stent as a possible model of hypoplastic left heart, because you know that there are no large animal models of hypoplastic left heart, and so we try to copy or try to elaborate an animal model of hypoplastic left heart. And this is one of the interesting cases, and I think that Christian has shown it yesterday to you. There is a normal speckle tracking feature of the left ventricle with a nice longitudinal strain from the base to the apex, which is this form or this figure you would expect from the left ventricle. And then after the occlusion of the foramen ovale and the sudden drop of inflow into the left ventricle, you see that the longitudinal strain of the apex regions has dropped dramatically, and shows a very different pattern of longitudinal strain. And this was a case we have done before the implementation of the myocardial function analysis with Toshiba. And we have here, and this might be a case, for example, where these tools might be of additional value. You see here a small left ventricle with a abnormal mitral valve, and you see here, because the pointer is not working on this screen, you see here that the foramen ovale is sealed and bulged into the right atrium, and you see here the abnormal pulmonary vein spectrum, which you would expect in those cases. And there we opened the foramen ovale, and in this case we did it by laser. And you might say, okay, this is not the case that this has opened, but the color Doppler shows a bidirectional flow via the foramen ovale. And this is another case of where this might be of this speckle tracking tool might be of interest, because here you see again what is called foramen ovale aneurysm, and that the foramen ovale is bulging into the left ventricle, into the left atrium, and the left ventricular inflow is, you see that this is deviated by this foramen ovale. This is the left ventricular inflow, and this is a very small inflow via a small mitral valve. And you see it here in the transverse four-chamber view that this foramen ovale is bulging, and this leads, because this diminishment of left ventricular inflow might lead, in some cases, to retrograde aortic arch flow, as you see here, like in hypoplastic left heart. And you know that in some cases you might test with maternal hyperoxygenation whether pulmonary vasculature is the function of the pulmonary vasculature, or to load the left ventricle. And in those cases it might be of interest to load the left ventricle by application of oxygen to the mother, and then it's only possible in the third trimester, because then the pulmonary vasculature of the fetus reacts to oxygen, and then you would expect an increase into increased return of pulmonary venous system to the left atrium, and more blood flow into the left atrium, and more load of the left ventricle, and this might increase again the ejection volume ejected by the left ventricle, and then again antegrade flow in those cases. And this has been reported by Rajcik, and we perform those tests again in those cases, and it works. And there, speckle tracking might also be of interest, because you might see before the intervention and after the intervention, you might see differences. And again here, this was a very recent case, and I think Christian showed it yesterday also. This was a case of aortic stenosis, and you see here again the alteration. If you compare this pattern of longitudinal strain of this left ventricle to the pattern of this here, you see that again, like in the animal model of decreased inflow, you see here that the longitudinal strain pattern has altered. And also on the right side, you might expect some, I would expect in those cases some alterations of the septal longitudinal strain, because we know that, as I showed you from the pulse wave data and color-coded data, that there is an alteration in right ventricular function, namely in the case of in the name of endocardial fibrillar elastosis. And endocardial fibrillar elastosis is an often seen pattern in critical aortic stenosis as well. As I told you, we do not have many patients for cardiac intervention actually in Gießen, about 5 during the year only, but we are trying to get more involved into this field by the access, as I told you, of the hepatic vein. And the group of Tworetsky in Boston probably has the largest experience with opening of aortic valves, but as I told you, transthoracically, and they examined this and published it in Fetal Diagnosis and Therapy, but not with Toshiba machines, and they saw that in those cases which evolved to biventricular repair afterwards, they had an increase of strain, of longitudinal strain, and also of circumferential strain in the left ventricle, and also in the septal right ventricular longitudinal strain. They saw an increase in those cases which evolved to biventricular after valvuloplasty. And this corresponds to our impression and what I showed you on the speckle tracking movies. So for the last slides, yes, I would say that maternal hyperoxygenation is probably the simplest fetal cardiac intervention without the need of needling, and we use it as a test. For example, as I told you, for the evaluation of lung hypoplasia in the field of diaphragmatic hernia, or in the field of sealed foramen ovale, to know whether the pediatric cardiologist has to be in the delivery room to perform a catheter procedure immediately after birth. And we are getting involved in the field of a study where we think about using maternal hyperoxygenation to induce growth of left heart structures in some kind of congenital heart disease, but there one has to say that the data are too preliminary to show here, and also one has to say that there's an issue of brain and oxygen in the fetus, and this has to be discussed more deeply, probably in the animal model, whether oxygen application, a long-term oxygen application during gestational age, during the third trimester, would perhaps damage fetal brain by free radicals, for example. So one has to be very cautious about this, but speckle tracking is also there, probably a good tool to evaluate myocardial function. So to conclude, we saw that with different techniques, we saw that myocardial function was altered in hypoplastic left heart and was even more altered in the type of hypoplastic left heart with endocardial fibroelastosis. And we think, and not only we think, but also the pediatric cardiologists and other teams, they think that this might be valuable information for the whole team and for parental counseling and for decision making after birth. But we will see whether this holds true. And I also showed you that the feasibility of those techniques is possible. You have to have a learn curve, but these techniques, they are possible to use them in clinical, daily clinical routine. And as I told you, we think that speckle tracking is of additional value in those cases before and after cardiac intervention. Thank you for your attention.